Dear all, thank you very much for sharing my presentation with you. And this presentation will be about a layer that we do not talk about that much in injectables. And that is the SMAS. So this is my disclosure. And we know the SMAS. We all know that it is a three-dimensional fibrous network. It mainly divides the superficial and the deep fatty layers of our face, and it transmits movements of the facial muscles. And in the SMAS, the nerves and the blood vessels find a way to travel through, and it's a safe pathway. So we know the SMAS. Before I continue, let me very quickly introduce ultrasound to you for those not familiar with ultrasound. Just use your common sense. Everything that is hard or dense in your face will look white. So ultrasound waves penetrate through skin, and if they hit something hard, they will reflect and it will look white on your screen. So everything that's hard, that will be bone, teeth, fascia, SMAS, calcium hydroxyapatite as a filler. And then the opposite, of course, is if structures contain a lot of fluid. So that would be vessels, cysts, hyaluronic acid. Muscles also contain a lot of fluid. They will look dark gray. So you just use your common sense and you will find your way around in ultrasound. Now, let's have a look at this image. And the probe is in a horizontal way placed on the zygoma. So just use your common knowledge about anatomy. The last layer is bone. That's a hard layer and it looks white. So this is the zygomatic bone. Then on top, you see a black layer. That's ultrasound gel containing a lot of fluid. And then you know from your anatomy, we have skin, superficial fat, deep fat, and the SMAS is dividing those two layers. So skin, superficial fat, deep fat, and these four fibrous sheets are the SMAS. And as you can see with ultrasound, it is a very true existing layer. If you would measure it, it is almost as thick as your superficial fatty layer, which you can see here. And which you can see here, it may vary. So in this person, it is actually thicker than the superficial fatty layer. So it is not that it's not existing. And now have a look. We started at the jawline, parotid gland, the SMAS on top here, and I can follow the SMAS throughout the whole face because your SMAS is everywhere. We're passing now, the probe is vertical, you can see that. So we started with the SMAS at the jawline and now we continue over the zygoma in a vertical way. Here the four sheets that you see, the fibrous sheets is your SMAS. We continue now in the temple. The name is changed. We call it now the superficial temporal fascia, but it's still the same layer. And the crest of the forehead, we can follow it into the forehead where it becomes the frontalis muscle. And now if we put the probe horizontal again, superficial temporal fascia, here it is. We move now into the midface, the zygomatic arch first, superficial fat, deep fat, divided by the SMAS. Here again, the SMAS, the SMAS, the SMAS. Keep your eye on it. You can follow it everywhere throughout your face. So it is a layer that we have everywhere in the facial area. And still, we do not talk that much about the SMAS. So I did some search in the literature with guideline fillers, fascia, consensus filler, fascia, SMAS, guideline filler, SMAS. I could not find a guideline. I couldn't find a consensus that was talking about the SMAS that would tell us, listen, do not inject in the SMAS or do inject in the SMAS. We do tell people that they should inject in the superficial fatty layer, that they should inject in the deep fat. Do not inject in muscles or arteries, but we leave the SMAS as an open space. And look what we have here. Again, this is the zygomatic area, the bone, deep and superficial fat, and we find filler everywhere injected in this SMAS layer. Can you see that? And because the SMAS, this is hyaluronic acid, it would look black, it contains fluid. And because it's injected here accidentally in the SMAS, it will redistribute everywhere where you have SMAS. So in this case, it goes to the midface. So here we have the zygomatic arch, all hyaluronic acid. It's dispersing the SMAS. So instead of 4 nice layers, we now see a layer on top, a layer underneath, and some layers here. But it's completely dispersing the SMAS, and you could follow it all into the midface. And if we follow it backwards, you can also follow it into the temples. This is the other area. The same thing happened. You see that? The hyaluronic acid is not in the superficial SMAS. It's not in the deep fat. It is actually injected in the SMAS layer. That may happen because of several reasons. It's actually unintentional filler placement because we do not advise to inject in the SMAS. And this is a cannula. Here we have the superficial fat compartment, the SMAS, the fascia SMAS enveloping it. And you can see that without any problem, the cannula is able to penetrate the SMAS. Here you can see it again. This is a 25 gauge cannula. And with no problem, you're able to get the tip of your needle in the SMAS and leaving your product in this layer. Another way that we can have filler in the SMAS is with backflow. So I hope you realize this is the zygomatic bone. The SMAS is in the middle, superficial fat, deep fat. We're injecting now here hyaluronic acid. And to get through the deep fatty layer, here you see the needle, you have to pierce through all the layers above it. So you have to pierce through skin, superficial fat, the SMAS, to inject your product in a deeper plane. And what you will see here with ultrasound is that you also fill, so my needle is here, but you also fill the tract that you created with your needle, leaving filler in the right place, but also leaving filler in the superficial fatty layers and here in the SMAS layer. And this is something that you cannot avoid because there is backflow. Here you can see there is always backflow of filler because you have to pierce through all those layers to get in the deeper plane. Here again, you can see that this is the chin. The needle is now aiming for the periost. You can see sometimes the probe moving, so it looks like the needle is not stable, but that's actually probe. Here again, we created a tract, and can you see that the hyaluronic acid is first filling the tract that we created, and once all the product has filled up this tract, then you will see that we have a bolus injection in the deep fat of the chin. So now here we inject a bolus, but there is already product in all the layers on top of it. So there will always be backflow of filler through the tract that we created. And this is a bigger 22 gauge cannula, and you see that there's more filler in a bigger tract than with a smaller needle. See that? So this is the second reason why we have filler in the SMAS. Then, of course, again, you can see that here, zygomatic bone, superficial fat. You take your needle, you feel the bone, but accidentally you inject all your filler. Let's go back one more time. You inject your filler in the SMAS. So the SMAS is here. It may be very tight in some persons, deep fat. Now here comes your needle. You feel the bone. So you assume that you are injecting in the right plane. But what you don't know is that you push down the SMAS, and instead of injecting in the deep fat on the periost, you inject all your products. So if you look afterwards with ultrasound, you see there's no product in the deep fat, no product in the superficial fat, and it's all 0.2 milliliter is now in the SMAS. And now it can migrate. It may take months, and very often your skin is very forgiving and it's no problem at all. But it may also lead to inflammatory nodules and to migration of these nodules. And if you want to, you can look it up. So here is our website, and there are a lot of free to download articles on it. So what happens if you have backflow of filler, or you get with your needle into the superficial fatty plane, but also in the SMAS, or you just inject everything in the SMAS? You will see, if you look with ultrasound after your filler treatment, you will see that we leave product here in this layer. So you saw this hyaluronic acid injected in the SMAS, hyaluronic acid, and you can see that because it's covered actually with fascia. The fascia is on top and underneath, and here it continues its course. Here again, calcium hydroxyapatite in the SMAS. It's not in the superficial fat, it's not in the deep fat. You have to move around with your probe to visualize that it is actually in the SMAS. This is the last layer of the SMAS, so it's more difficult to visualize, but you can see here that the fascia is opening here. You see that? The last layer, it's opening here, and it will migrate here again, the last layer of the fibrous sheets, and these are the other layers of the fibrous sheets. This is the propus vertical. So here we have the mandible, the masseter muscle on top, parotid gland, superficial fatty layer, and it looks like this hyaluronic acid is injected in the superficial fatty layer. But if you look closely, here we have the SMAS. The SMAS is now opened. This is the last layer of our SMAS, and the filler is actually injected in that last layer, and it's been pushed up in the superficial fat. So it looks like it's actually in the superficial fat, and you have to move around with your probe to visualize in which layer it is actually injected. So you can also see a little bit of the shape. They have like all this oval compressed deposit together. So here, can you see it's enveloped? Here it is also in the SMAS, partly in the superficial fat, partly in the SMAS, covered with SMAS, hyaluronic acid, oval-shaped deposit. And it will migrate. Here it's partly in the parotid gland, so you can follow with ultrasound what happened afterwards with your treatment, and you will find that it's very often in that SMAS. And again, it doesn't have to be a problem, but it might lead to problems, and what we see is that it leads to nodules, sometimes directly after treatments. Sometimes it may take months to travel through the SMAS and lead to visible or palpable nodules. It redistributes, so injected in your temples, it may go all the way down to your mandible or even into your neck. It may go from your zygoma to your midface. And as the SMAS is attached to your dynamic facial muscles, it may lead to muscle impairment. We also see malar edema and swelling from filler injected into the SMAS or the fascia. Nodule. If you put the middle of your probe on this nodule, it will correspond with the middle of your screen, and that's here. And this is calcium hydroxyapatite injected in the SMAS. Skin, superficial fatty layer, and you can see underneath the SMAS, and here the calcium hydroxyapatite is actually injected in the fibrous sheets, giving rise to a palpable and visible nodule. Here a nodule, here irregularities, here irregularities. And if we take the ultrasound, this is the superficial fat compartment enveloped with fascia, and you can see that this first nodule is injected into the SMAS layers. Here it's on top and above. And if you move around with your probe, you can see, I make small movements, that there was another deposit. Here is another deposit, and you can trace down all those deposits of hyaluronic acid that migrated or actually were redistributed in this fascial layer. Dynamic muscle impairment. Before, so this is somebody who complains that her smile changed. And this is before we dissolved the filler in the SMAS. And this is minutes after we dissolved the filler in the SMAS. What happens? Zygoma, and then the zygoma dives into the maxilla. We have the zygomatic major muscle, but that's continuous with the SMAS. And here we have hyaluronic acid injected into the SMAS layer. It's covered above and underneath. Here you can see that, and hyaluronic acid. And now we make somebody smile. Look, here's the contraction of the zygomatic major muscle. Here we have the hyaluronic acid. Have a look. This is the maximum contraction. You see that? That was here again, the maximum contraction of her smiling and using her zygomatic major muscle with hyaluronic acid in the SMAS. So we dissolve this deposit. Here's a 27 gauge needle. We are now in the hyaluronic acid filler deposit. We're using 30-50 units, a low amount because we're very specific. And after this dissolvement, this is now the maximum contraction. You see that? It's an improved contractility of the zygomatic major muscle because the HA is no longer influencing that in a negative way. Malar edema or lower eyelid edema, you have to remember that in the SMAS, we have the nerves and we have blood vessels. We have the arteries and the veins traveling in it or traveling through it. And this is what you normally would see. This is the midface around the infraorbital artery. Here you see the infraorbital notch and the infraorbital artery coming out. It's piercing through the SMAS, giving off branches, perforators to supply the superficial layers of skin and fat. Here again, this is a vein piercing through. See that? They have to pierce through this SMAS layer. And if we compress the vein by filler material, it may lead to malar edema. And sometimes they truly, so this again is the mandible, parotid gland, masseter muscle, and here you can see that sometimes they even travel completely through the SMAS. So if you block that accidentally with your filler, your vessels may have problems and it may lead to edema. So here we can see that in one eye. This is a severe case of lower eyelid edema, and these were already dissolved, had prednisone antibiotic treatment, but let's be honest, where is the redness? So is this inflammation? And if we look with ultrasound, I hope you recognize that this is hyaluronic acid filler in the SMAS. It looks cloudy because there's so many edema, but I want you to notice that we do not have a lot of superficial flow. Not what you would expect normally. We have a tiny bit here. We're lacking good flow here. So we're going to dissolve the hyaluronic acid in the SMAS layer. It's covered here and it's covered underneath. It's not in the superficial fat, not in the deep fat. So there is a 27 long gouge needle entering in the hyaluronic acid filler deposits, we're dissolving it. And we do this under duplex because we want to visualize the flow that comes back. And the flow that you see after ultrasound-guided injections will always be a dilated flow. That is what always happening when you inject. But this is flow that we did not have. You see that? And now we have flow that is supplying the superficial fatty layer, piercing through the SMAS, and then we'll go into a deeper layer. And if we see this patient back for control, she will have, for a checkup, she will have the same vessels, because you release them actually as the hyaluronic acid were compressing these vessels. See that? And this may take months. You may be injected on your zygoma in February and have malar edema in June. Directly after treatment, so this is before treatment, and directly like 10 or 15 minutes after treatment, there is already a good improvement. And in the days after, there will be a better improvement, but this is too quickly for lymphatics. So your lymphatic system in the mid-phase do accompany the big veins. So we think it's partly due to vein compression and partly due to impaired lymphatic systems. Also swelling and a bit of redness, but the question is this redness caused by inflammation or by venous compression? The probe is on the zygoma in the midface, zygomatic arch, superficial fat, deep fat, and again, all filler was accidentally injected in the SMAS. So it's covering above and it's covering underneath the hyaluronic acid. And again, we put the color box on and you can see that there's not much fluid. But because it's lower now, you don't see malar edema. These patients may complain, here again, 27 gouge needle dissolving the hyaluronic acid. These patients may complain that they have redness after sauna, after sporting, in warm weather. It may go up and down, it may be persistent sometimes. And again, look, there's not much flow here in this layer. We dissolve the hyaluronic acid. The image again is quite cloudy because there is a lot of edema in this area. And we dissolve hyaluronic acid and instantly again, you see improvement of flow, a bit dilated. That is because you injected in this area. But this flow will be there also if you see her back in a week time. So you may compress vessels in the SMAS because they're stuck there. They course in that layer, and there's no way they can move back or change in course. Late onset nodule, injected with hyaluronic acid, and this nodule appears months later. Again, antibiotic treatment was given. Steroids were giving, and looking with ultrasound, we see the same pattern, hypervascularization. So we think that the redness is the hypervascularization trying to compensate for an area with hardly any flow. So here we're just checking if we see anything else here. But the only thing we see is no filler in the superficial fat, no filler in the deep fat, a lot of edema, hypervascularity on one side, and then the side that will dissolve, you see that we do not have a lot of flow. So same procedure, 27 gouge long needle, dissolving the hyaluronic acid in the SMAS. And what you will see if these patients come back is that the hypervascularity, leaving to redness, will disappear and becomes normal, and that you have restored flow in the area where the filler was compressing the vessels. So you see that actually it happens at the needle. You see the flow being released. So here you can see that restored flow. And what we actually was, the message of this whole presentation is that I would like to say, hello SMAS, welcome in our injectable world. It's an existing plane, we all know that, but it does play a game in the adverse events that we see. And I hope that by introducing the SMAS, we create awareness for these layers in injectables. Thank you so much for your attention. You will find more ultrasound information on my Instagram site. And if you go to cutaneous.org, you will be able to download free access publications that we published on these subjects. Thank you very much.